Welcome to Holmes on Health, the podcast where nutrition, fitness, and hormones meet health span, and science meets real life. I'm Dr. Alan Holmes, a recovering emergency physician turned expert in hormone optimization, metabolic wellness, and living life fully optimized. Each week, we dive into the tools, truths, and evidence-based therapies that help you build a stronger body, sharper mind, and more vibrant life. Whether you're curious, confused, or already optimizing, you're in the right place. Thank you for being here. Let's get into today's episode. Hello, and welcome to another episode of Holmes on Health. Today, we're going to be talking about estradiol. It is a foundational hormone to women's health. Today, we're going to focus in on those women that are in menopause or post-menopause. We're going to cover the difference between what it means when we say natural estradiol or bioidentical estradiol versus synthetic estrogen, like conjugated equine estrogen. Some of this is going to be a bit of review from last week's episode when we dove deep on the Women's Health Initiative, but these terms and these topics can be so complicated, it is worth the review. The more times we hear it, the better we understand it. We're going to talk about how estradiol works in the body, and we're going to talk about the evidence of its benefits even far beyond symptom relief. So let's start with the difference between bioidentical estradiol and synthetic estradiol. When we're talking about synthetic estradiol, or when we're talking about synthetic estrogen, I should say, we're talking about conjugated equine estrogen. The brand name of that is called Premarin. It is made up of 10 plus different types of estrogen. Well less than 10% of it is actually 17 beta estradiol. Conjugated equine estrogen, as the name would imply, is sourced from the urine of pregnant mares or pregnant female horses. So multiple different types of estrogen in that product. Only a handful of them are actually known to the human body. So that is synthetic estrogen. That is what was studied in the Women's Health Initiative that we discussed last week. The distinction between that and estradiol, specifically in the form of 17 beta estradiol. There's also a 17 alpha estradiol. Primarily what we're talking about is 17 beta estradiol. So this is isomolecular or bioidentical. Why is that important? What do I mean by that? Again, we're talking about molecules that look exactly like the estradiol molecules that is made by the ovaries in women up until the time in which they go into menopause. That is important because if they are isomolecular or identical, it means that the receptors at a cellular level recognize those molecules, they know what they are, and they know exactly what they're supposed to do with them. That's the important distinction. We'll get into that more even as we go along. So let's start with benefits of estradiol as related to women in menopause. Well, first, we're going to start with symptoms. Estradiol plays a huge role in improving and or eliminating the vasomotor symptoms that women experience when they go into menopause, even oftentimes before menopause. These are the hot flashes, the night sweats that can be absolutely debilitating. It also plays a role in sleep. If you're up super hot and you're sweating, this is going to negatively affect sleep. There's also the mood changes that happen for women as related to the lack of estradiol when they go into menopause. So if estradiol did nothing else for women in menopause and postmenopause other than treat the symptoms or improve the symptoms of the vasomotor symptoms of menopause, it would be well worth it. What we're going to unfold here today is all of the other benefits of estradiol in addition to these very important vasomotor symptoms and benefits. So let's start with debunking a myth or a hypothesis. The old teaching was that, okay, fine, you go into menopause, we can give you a little bit of estrogen to make you feel better, but there is a window of time in which it is safe. And it is called the 10-year window or called the timing hypothesis. So there are some providers, even still today, that would say, okay, well, I will put you on some estrogen for a period of time, but once we get to the 10-year mark, you have to stop because after that, it's dangerous. It's going to make you have a stroke. It's going to make you have increased risk of blood clots, etc. There are multiple other recent studies that have sort of debunked this. One of these was the ELITE trial in 2016, where it showed that estradiol slowed atherosclerotic progression, regardless of the time since the women had gone into menopause. Another study called the DOPS trial, a Danish study in 2012, showed that there was a 52% reduction in cardiovascular disease when started early, but long-term safety was also confirmed in this study. So even past the 10-year mark of taking bioidentical estradiol, it is both safe and it is both effective. This was also addressed in Levy and Simon's 2024 review of the WHI. In that, they said what we have said on this podcast before, that those conclusions were way overstated and that estradiol remains safe and beneficial even beyond the 10-year window. So where did the window come from? Why is it talked about? Well, here's the important distinction. The window was about conjugated equine estrogen. The window was about Premarin. And as we said, those two things are not the same thing. And here's the difference. The potency of conjugated equine estrogen, meaning Premarin, is far greater than that of bioidentical estradiol. So it was because of the potency that there was an increased risk past 10 years in menopausal women that were undergoing therapy. That 10-year window does not apply to oral estradiol. It only applies to Premarin and synthetic estrogens. There's never been a study linking bioidentical estradiol to an increase in stroke in a randomized controlled trial. And the reason, again, is that estradiol is not as potent as Premarin. So the window of opportunity in Premarin, 10 years, because there can be an increase in risk past 10 years. And this is because of the buildup of plaque in the artery walls over that period of time. I mentioned in the last podcast, and I'm going to go through it again here, that Premarin causes a significant increase in an enzyme called matrix metalloproteinase 9, MMP9. This enzyme degrades the fibrous cap that makes up a cardiovascular disease in the wall of the artery. And if that gets degraded and therefore ruptured, it will cause a clot. And yes, this can increase risk of stroke and events. Estradiol, 17-beta estradiol, does not cause this big increase in matrix metalloproteinase 9. It is a much more subtle increase to which the levels of enzyme present actually stabilize plaques and can reduce plaque burden slowly over time. So very potent conjugated equine estrogen, big spike in matrix metalloproteinase 9 enzyme causes breakdown of the plaque caps, destabilizes them, leads to potential rupture. That leads to cardiovascular events. Again, this does not happen with bioidentical estradiol. And that is why conjugated equine estrogen studied in the Women's Health Initiative, there was a window of safety that does not apply to 17-beta estradiol. Now, what about blood clots? Well, let's start with the patient that has a history of a blood clot or has known to have a family history of blood clot or known to have a genetic predisposition to blood clots. Well, if that is you, that woman has a 50% increase in developing a blood clot, whether she's on hormones or not. Now, if you add Premarin, synthetic conjugated equine estrogen, that further increases the risk of blood clot, particularly with age. And if you give them Prempro, which is Premarin plus the synthetic progesterone, Provera, the increase even further increases. However, there are no studies that show that bioidentical 17-beta estradiol increases the risk of venous thromboembolisms or blood clots, whether given transdermally or given orally. This is important because some providers, some literature would suggest that, well, you won't get a blood clot if you take it transdermally. And it is true. There are no studies anywhere that shows a transdermal application of estradiol increases risk of blood clot. And this is because of the synthetic estrogens not going to deliver and having what they call the first pass effect. However, there are also no studies when you delineate out 17-beta oral estradiol. There are no studies that 17-beta oral estradiol causes blood clots. So from a safety standpoint related to blood clots, whether transdermal or oral, there are no studies that say that it's not safe. So let's keep going. What are the other benefits of estradiol in menopausal and postmenopausal women? We'll start with bone health. In the Women's Health Initiative study that studied conjugated equine estrogen, there was over 10,000 women that were looked at, and the estrogen therapy group had a reduction of hip fracture of 39%. And there was a total fracture reduction of 30%. So estrogen, even conjugated equine estrogen, showed us significant evidence of bone protection in postmenopausal women. The Danish Osteoporosis Prevention Study, what is known as the DOPS trial, 2012,
1,000 postmenopausal women that were randomized into an estradiol group and a no therapy group. And they were followed out for 10 years. There was actually an extension where they were followed out for a total of 16 years. The findings in that study showed women on hormone therapy had a significant reduction in osteoporotic fractures compared with women that did not get hormones. That study found a 43% reduction in fractures at the 10-year mark. And even at the 16-year mark, there was still a 34% reduction in fractures. So bioidentical estradiol studied in the DOPS trial effectively prevented fractures for menopausal postmenopausal. Let's look at a third trial. There was a meta-analysis that was a randomized controlled trials. This is from 2002, and it showed that estrogen therapy reduced vertebral fractures or spine fractures of the back by 34%, and non-vertebral fractures by 29%. This included hip fractures. So again, this is a pooling of evidence from multiple different studies, multiple different looks that confirmed estradiol lowers the risk of fracture. So let's move on to heart health. Does estradiol in women play a role in heart health? Again, same Danish osteoporosis prevention study, the DOPS trial, 1,000 women. This showed that there was at 10-year and 16-year follow-up, a 52% reduction in the composite endpoint, which was death, heart failure, and heart attack. So women went into menopause, estradiol was started soon, and it led to a significant decrease in the number of cardiovascular events and deaths. There is the ELITE trial, early versus late intervention trial with estradiol. This was in 2016. 43 healthy postmenopausal women. Some were given 17-beta estradiol. Some were given placebo, meaning they were not given hormones. Within 6 years, the estradiol group showed a slowed progression of carotid intima media thickness. So that is the thickness of the wall of the artery, of the carotid artery. This is a precursor or a way in which we can look for evidence of cardiovascular disease. Meaning if you've got thickening of the wall of the artery, that's probably disease there. If it's in your carotid artery, it's probably in other arteries like the coronary arteries surrounding your heart and supplying blood flow to your heart. In this study, the women that got estradiol had a slower progression of the thickness or the development of disease than the women that did not get hormone therapy. Estradiol therapy protects vascular health, particularly when it is started early after going into menopause. There was another meta-analysis that this looked at 19 different randomized controlled trials, over 40,000 women. This looked at 19 randomized controlled trials, over 40,000 postmenopausal women. In the younger women, less than 60 years old and less than 10 years out from menopause, estrogen therapy was associated with a significant reduction in coronary artery disease events. The relative risk was 0.52. That means a 48% reduction in cardiovascular deaths. And there was no increase in all-cause mortality, meaning nothing bad happened. There wasn't an increase in death from stroke or from blood clot or from cancer or from anything else. 48% lowering in coronary heart disease. That's a really, really big number. That is better than statins. It's better than blood pressure medication. It's better than all these other things that traditional medicine does. Estradiol plays a major role in reducing risk of cardiovascular disease in women. Now, why is this so important? Because the number one cause of death in women, cardiovascular disease. It's not breast cancer, although that's high. It's not fractures, although that's high as well. We want to prevent all that. But the number one, cardiovascular disease. And if we have a way to safely give bioidentical estradiol, and we have studies that show that that reduces the risk of events by 48%, we should listen to them. Now, let's move on. Let's get into what can estradiol do for my brain health or my risk of dementia. There was the Cache County study in Utah, 2002. This was published in JAMA. It looked at over 1,800 women, and it found that women who used hormone therapy, meaning estradiol, had a 30% reduced risk of Alzheimer's disease compared to those that didn't get any estradiol. When it looked at these women even past 10 years, there was even greater protection shown. So both early and sustained use of estradiol in menopausal women lowers the risk of dementia. There was a study at Kaiser Permanente, an observational cohort, 500 women. were followed for 40 years, evaluated for hormone therapy as related to dementia. They showed that midlife estradiol therapy, meaning at menopause, was associated with a 20% lower risk of dementia. Takeaway again, starting estradiol around menopause is brain protective. There was a study, Rochester Epidemiologic Project at the Mayo Clinic. This was done in 2019. This looked at women that had undergone bilateral oophorectomies, meaning they had had both ovaries removed, therefore were sent into menopause because they were no longer making estrogen. They were followed out long-term. The women who received estradiol therapy until at least the average age of natural menopause had a significantly reduced risk of cognitive impairment and dementia compared to those that didn't. Again, estradiol replacement therapy in women, even those with premature estrogen loss related to removal of ovaries, shows strong neuroprotection. Let's move on. There is something termed the genitourinary syndrome of menopause. This is symptoms involving the genitourinary symptoms that women will develop after they go into menopause. This includes vaginal dryness, it includes incontinence, frequent UTIs, those types of symptoms. So let's look, what does the literature show as far as improvement of those symptoms? Oral versus topical estrogen therapy on what's called the lower urinary tract were the symptoms of that. This was looked at in 2006. And it showed that both oral and topical estrogen significantly improved urinary frequency and nocturia, meaning nighttime need to urinate, over just a 3-month period. Both of these deliveries increased blood flow around the bladder neck and the urethra. And this was measured by ultrasound, so looked at accurately. There was an improvement in stress incontinence as well, which if you're a woman, cough hard, laugh hard, sneeze hard, you know what I'm talking about with this. And this study showed a significant improvement in that. This was 73% in the oral group and 60% in the topical estradiol. There was another study showing the systemic evidence of low dose estrogen for genitourinary syndrome. This was as recent as 2025. It said that the available evidence supports that low dose estrogen therapy alongside vaginal estrogen therapy is effective for treating genitourinary syndrome of menopause. This eliminates both vaginal symptoms as well as urinary symptoms. So for women, menopause and beyond, this is a really big deal. I mean, what woman wants to get frequent UTIs, which could lead as they get older to unnecessary use of antibiotics, can lead to sepsis, which can leave them hospitalized. The issues with dryness that can cause pain with intercourse or inability to even have intercourse. The issues of incontinence, which can be both embarrassing as well as just in general life affecting in a negative way. And estradiol is showing that it improves all of these types of symptoms. One more, a clinical review on modern menopausal therapy. This was done in 2023. This review emphasized that systemic estrogen therapy, including oral estradiol, is an effective option not only for vasomotor symptoms, but also treating genital syndrome of menopause. This was in the American Heart Association circulatory review. Another meta-analysis shows that vaginal estradiol reduces recurrent UTIs. This was 4,700 women postmenopausal and found that vaginal estrogen significantly reduced the risk of recurrent UTIs. There are estimates that say that the United States of America healthcare system could save billions, with a B, billions of dollars by significantly reducing urinary tract infections in menopausal and postmenopausal women because of the decreased need for antibiotics, the decreased hospitalizations, including ICU hospitalizations because of sepsis or severe infection related to urinary tract infection. Could save billions by simply giving a relatively cheap estradiol. So let's look at one more. Vaginal estrogen lowers sepsis and mortality. A cohort study using a database of multi-million patient records over a 3-year period. So very, very large database. Now, this is a cohort study. This isn't the best of all studies. This isn't a randomized controlled trial. But when you start looking at millions of patient records and they all start telling the same story, it kind of increases the validity of the evidence. So it assessed outcomes in women greater than 55 years old with recurrent UTIs. Sepsis was reduced from 19.4% to 10.6%. A reduction of 51% with vaginal estrogen. Death or mortality dropped from 1.54% to 0.42%, a 73% reduction. Hospitalizations were reduced by almost 22%. Conclusion, postmenopausal women using estradiol significantly improved outcomes when it was related to sepsis, mortality, and hospitalizations. So let's look at hair and skin. That's important, I'm sure, to most women listening to this podcast. What can estradiol do to your hair and skin? So we know that estradiol stimulates collagen production. We know that it improves skin thickness and elasticity. And we know that it reduces hair thinning and dryness. All that sounds pretty good. 1994 study was a randomized controlled study of postmenopausal women receiving transdermal estrogen versus no estrogen. And this showed that estradiol significantly increased skin collagen content and elasticity compared to the placebo group. Skin thickness improved after 6 months of therapy. Another study, collagen and skin aging. This was done in 2005. It was a longitudinal study of postmenopausal women on hormone replacement therapy with estradiol versus a group of women that got no hormones at all. This study showed that estradiol therapy increased dermal collagen content by 30% and reduced skin atrophy. Improvements in skin hydration were seen, as well as thickness. Again, estradiol prevents and reverses skin thinning and dryness seen in menopause. So not only does it help your heart and your bones and your brain, it even helps your looks. There was a review of clinical and histological studies of estrogen on skin and hair. This was done in 2003. Showed that estradiol improves scalp hair density and reduces postmenopausal hair loss by prolonging the growth phase of the hair follicles and increasing scalp perfusion. So many women, I hear this all the time in my practice. My hair is falling out. My hair has been falling out. In part, maybe not the whole story, but in part, the story of that is a lack of estradiol. And replacing estradiol can help support hair growth and reduce thinning of hair in menopausal women. So one more topic, one more question to go over. What should your levels be? I hope at this point we have established that estradiol is safe. And we have established that it's good for your bones and it's good for your heart and it's good for your brain. But does that mean that taking any amount of estradiol provides these benefits? Does it mean that as long as you're taking estradiol, it is going to provide benefits to all of this? Or do we need to be taking a certain amount of estradiol? Well, let's look at what the literature shows. A 2009 study found that postmenopausal women with serum estradiol levels below 60 picograms per milliliter had a 4.93 times higher odds of low bone mineral density compared to those with levels greater than 60 picograms per milliliter. A JAMA report in 2003 on ultra-low 17-beta estradiol therapy noted that women with estradiol levels below 5 picograms per milliliter experience a 0.8% annual hip bone loss, while those with levels above 10 picograms per milliliter maintained bone better. There was another analysis that on postmenopausal women with estradiol concentrations above 5 picograms per milliliter had a significantly better femoral neck T-score. This is one of the ways in which they compare bone strength from healthy bone strength to better than healthy bone strength to less than healthy bone strength. It's called a T-score. But those above, those that had a estradiol level of greater than 10 picograms per milliliter had an even higher bone mineral density across all skeletal sites. So greater than 5 was good, greater than 10 was better. A 2025 review in Menopause journal indicated that an optimal plasma estradiol range of 60 to 150 picograms per milliliter was ideal for symptom relief and prevention of bone loss, with 100 picograms per milliliter achieving full resolution of hot flashes and bone accretion. So, as our mentor, Dr. Neil Rouzier, often asks, what do you want your levels to be? Let's look at cardiovascular disease, heart health. There was a recent cross-sectional study in 2024 that observed that women with lower estradiol levels had higher prevalence of abdominal aortic calcifications. Those in the lowest estradiol group, around 2 to 3 picograms per milliliter, had a 2 to 2.5 times greater abdominal aortic calcification risk compared to those with higher levels in the 7 to 38 picogram per milliliter range. We know that estradiol enhances endothelial function as well as nitric oxide signaling, offering vascular benefits. What do you want your levels to be? Brain health, cognitive health. 2002 JAMA Neurology study suggested a threshold for elderly individuals with endogenous estradiol levels under 15 and a higher dementia risk. A 2024 cohort found that higher estradiol levels correlated with better cognitive performance, specifically improved processing speed, attention, and working memory. So, what do you want your levels to be? All right, let's wrap this up. So, I hope you have learned from this episode that estradiol is safe and that it is far more than just symptom relief, as important as the symptom relief is. It protects bone, it protects heart, it protects brain. It is good for your skin and hair. It is good for genitourinary symptoms in menopause. The key is using the right form, that is bioidentical 17-beta estradiol, not conjugated equine estrogen, not Premarin, and it is using it at the right dose to achieve optimal levels. Estradiol is a game changer, but estradiol requires the right or optimal serum levels of estradiol to really tease out the benefits, to really provide the benefits that it can bring. So I say that part to say that if you go to your doctor, your OBGYN, your primary care physician, and they give you low dose estradiol, I'm just going to give you a little bit to hopefully just help the hot flashes a little bit, or maybe to help your genitourinary symptoms a little bit, that may not be good enough. Oftentimes, primary care physicians and GYNs will not check levels. They will say, well, I have you on it. I don't need to check the levels. Well, as we just discussed, the levels do matter because we want levels north of 60 picograms per milliliter. Maybe we want levels of 100 or 100 plus to really know that we're getting the heart benefit, the bone benefit, and the brain benefit. So yes, you should want to be on estradiol if you're menopausal, postmenopausal. You should be able to confidently know that it is safe to want to be on estradiol, and you want to be on it in such a way that the levels are optimal. So some may or may not be enough. So levels matter. The last thing I would say is, just as I said last week, don't let outdated studies like the Women's Health Initiative and the fear that that brought keep you from evidence-based care like we've just went over. If you found this episode educational and helpful, please leave a comment. Let me know what your thoughts are. If you can share it with someone that you may think may benefit from this information, may answer some of their questions, please share it. And please leave a review, because that's what helps others find the podcast. Until next week, here's to living life optimized.
Thank you for tuning into this episode of Holmes on Health. If you found today's episode valuable, share it with someone you care about. And hit subscribe so you never miss a future episode. Want to get more of our content? Follow me on Instagram and YouTube at Alan J. Holmes MD. Until next time, here's to living life optimized. This podcast is for general informational purposes only and does not constitute the practice of medicine or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.